In this discussion, we will focus on dysrhythmias management and some NCLEX tips. So you already learned the identification of heart rate using a 6 seconds EKG strip. Okay, so for this one, the heart rate is 60 beats per minute. But also remember that there are also other ways to determine a heart rate using big boxes or using small boxes. So technically, if your patient 6-second EKG strip, when you look at between R to R, and when you count the big boxes, if there are only like 3 big boxes, the heart rate is technically 100 beats per minute. If the big boxes are 4, okay, between R to R, the heart rate is 75 beats per minute. If it's 5, the heart rate is 60, and if it's 6, the heart rate is 50. So when you count the big boxes in between R to R in here, there is 1, 2, 3, 4, 5 big boxes. So when you look here, it means that the heart rate is 60. But when you look at on the other R to R interval here, there's only 1, 2, 3, 4, and approximately 1 to 2 small boxes. Then your patient might have a heart rate of less than 75 beats per minute. So as you can see, there are other ways to determine heart rate. And in here, you've learned that there's 3 seconds and 6 seconds. But for exam purposes, and even in NCLEX, you can use the 6-second strip. And how would you know if it's 6 second? You have to look at the block mark in here. Okay, so in here, from here to here, that's 3 second. From here to here, that is 6-second EKG strip. And you'll be wondering how to get this 6-second EKG strip. Are we using the 12-lead ECG? Is it the same thing? It's different, okay? The 6-second EKG strip is completely different from the 12-lead EKG result. So the 6-second EKG strip, okay, can be obtained by doing a 5-lead ECG or even via 3-lead ECG. Okay, so with 5-lead ECG, and this is most commonly used in medical surgical unit, is that you put the electrodes, the 5 electrodes, and you can see here where to put it. Okay, is it on the right midclavicular? Is it on the left? Is it on the right lower? Is it the left lower? Okay, so this is the 5-lead ECG, and probably in the hospital you're working at or you're exposed for clinical, they're using 3-lead. Again, the same principle. Okay, now just a review for the conduction system. You already learned about SA node generating 60 to 100 bits per minute, while AV node is generating 40 to 60 bits per minute. The bundle branches here and the Purkinje fibers here generate less than 30 bits per minute. Okay, so the arrhythmias that are slower heart rate, like sinus bradycardia, it means that the SA node and the AV node are having problems. Or if the patient has AV blocks, then probably it's only the bundle branches and the Purkinje fibers are the ones functioning. Okay, but if it's a faster heart rate, you might be wondering then where the aberrancy or the arrhythmia is coming from, because SA node is only 60 to 100. It's because the aberrancy is happening. It's either because there are multiple focal points in here where the extra heartbeat is coming from, or probably the conduction is just going on circles. What do I mean by that? Like, for example, instead of going straight down to the bundle branches, let's say it keeps going back in here, or it keeps going back in here. So it's called reentrant tachycardia. Okay, we will discuss that in the faster heart rate or faster rhythms or arrhythmias later on. So let's move on to the first arrhythmia that we will talk about today. So the first one is sinus bradycardia. And sinus bradycardia means that the heart rate is less than 60. And as you can see here, when you count the R's, there's only 4. So that is 40 beats per minute. Okay? Or if you want to use the big boxes here, as you can see, the R to R is farther from each other. And remember, the farther the R to R is, the lower the heart rate is. The closer the R to R from each other, the faster the heart rate is. Okay, that's why earlier we discussed if there are 3 big boxes, your patient's heart rate is 100. So for sure, if the big boxes of the patient is 2, then probably the heart rate is probably 150 to 200 beats per minute. Okay. So what do we do with sinus bradycardia? Of course, the first thing we ask ourselves is, our patient asymptomatic or no symptoms? So if the patient has no symptoms, we just have to monitor and observe our patient. And not only that, you can also look back on the chart of the patient, see what's going on and why this patient's heart rate is very low. Because there are many reasons. For example, what if you have a patient who has a 55 beats per minute, and you look back, this patient has a history of hypertension, and the patient is taking beta blockers, calcium channel blockers, diuretics, and those can cause a lower heart rate, but it's controlled, and it's because the patient is taking some meds to control hypertension. So you really have to look on the patient's chart and investigate. Now, if your patient is symptomatic, it means that your patient has many symptoms, like patient is sweating, patient is pale, patient's having a hard time to breathe, or having an alteration in level of consciousness. You have to investigate what's going on with this patient. So American Heart Association released an algorithm in 2015. And remember that American Heart Association, they make an update in regards to ACLS every 5 years. Okay? And actually, they have an update last year in regards to the medications that we give to these patients who have dysrhythmias. And I will discuss that later on. And as a nurse, you really have to be updated all the time, and you have to know the current clinical practice. So, for sinus bradycardia, if your patient is symptomatic, you have to identify and treat the underlying cause. Of course, you have to know what's going on with this patient. And as you do that, you have to make sure that you maintain airway and breathing of the patient. You have to put O2, but remember, the oxygen therapy you put, the lowest is 2 liters nasal cannula, or you can bump it up to partial rebreather mask or non-rebreather mask. And it depends on the oxygen saturation of the patient, ABG, based on your respiratory assessment. And of course, you have to put your patient on cardiac monitor and monitor their blood pressure, because any changes in the heart rate of the patient can alter the cardiac output, which lead into lower blood pressure. So you have to look at that. You need an IV access because for sure you'll be giving some medications. You have to do 12-lead ECG to know what's going on. Is this patient having ST depression or ST elevation? We want to further investigate. Is this patient complaining of any chest pain? You have to further investigate. Now, here you can see the list of possible causes of sinus bradycardia. If any of this is a cause, then you have to give atropine. As you can see, atropine is the first drug of choice for sinus bradycardia. And as a nurse, you have to know the dosing, okay? The first dose of atropine you have to give here is 0.5 milligrams. And you can give this every 3 to 5 minutes, and the maximum dose is 3 milligrams. Now, as you can see here, this is the atropine available in the pharmacy. Okay, you can see this in crush cart, or even you can see it also in the Pixies in the medication room. Okay, so if atropine is not working, So as you can see here, if it's not effective, then you can do transcutaneous spacing. As you can see, it's the first choice compared to DOPA or epi. So you can do transcutaneous spacing, and I'm going to show you what is transcutaneous spacing here. So this is the LiPAC, the machine. They can use Zoll or they can use Medtronic, so it depends on where you work or where your clinical is. So transcutaneous, it means it's via the skin, okay? And this is a temporary pacing the patient that will help to increase the heart rate, okay? So as you can see, you have to put the pads on and you have to pre-medicate your patient because this will be painful, okay? It's like you're shocking the patient but in a minimal dosage. So you have to pre-medicate them. You can give morphine, 2 milligrams IV push, but remember, if this patient has chest pain, you have to remember that you cannot give morphine if your patient has right ventricular infarct, right? So again, you can use fentanyl. So either morphine or fentanyl to pre-medicating your patient before you start transcutaneous spacing. If transcutaneous spacing is not working, you can start dopamine drip or epinephrine drip, okay? And after that, here's the dopamine that you have to hang, or you can hang an epinephrine IV infusion. Okay? Now, remember, once you stabilize your patient, you have to consult EPS or electrophysiology studies. There are a group of physicians or nurse practitioner that places pacemaker or AICD or even life vest, but for this one the patient needs pacemaker, and all of you are already familiar with this pacemaker that you can see in the left upper chest of the patient. But the newest pacemaker now is the lidless pacemaker, okay? So the lidless pacemaker, I'm gonna show you. So you can see this is the old one right here, and this is the new one. It's like a bullet, okay? That you can see it's sitting on the left ventricle. Okay, so if you see that in any x-ray of your patient, then you know it's a pacemaker, okay? We don't have to panic. And as you can see, this evidence-based practice came out. This one came out, I believe, last year, October 2018. Okay? And again, because of technology, there might be, again, changes next year. We don't know. So you really have to be updated. Okay? And I believe some hospitals here in South Florida are using this lidless spacer now. So you really have to be familiar with it. One question that arises is this MRI safe? Okay? Can the patient gone through MRI? Again, there is a list of products in Medtronic website that is MRI safe. Okay, so again, you have to find out in the patient's chart if this patient's lidless spacer is Medtronic and is it MRI safe, and you can see the list on their website. Okay, and there's a lot of products now that are MRI safe. If they are not MRI safe, then of course your patient cannot have MRI. Okay? So now the next dysrhythmia that we'll talk about is sinus tachycardia. And sinus tachycardia means that the heart rate is more than 100 beats per minute. So when you count this 6-second EKG strip, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So this is 130 beats per minute. Is it regular or irregular? When you look at in every R2R interval, I believe this is a regular. Okay? So same thing with sinus brady. You have to know if your patient is asymptomatic or symptomatic. If they are asymptomatic, then you monitor and observe them. But of course, having a 130 beats per minute, you can ask the patient to do vagal maneuver. Okay, how do we do vagal maneuver? You suction the patient, you ask them to bear down. Okay, now with tachycardia, so you can see there's an algorithm also for tachycardia that American Heart Association created. So if they are symptomatic, okay, if they have symptoms, you have to do the following, okay? You have to identify and treat the underlying cause. And the most common causes of tachycardia or sinus tachycardia are fever. Probably your patient is in pain. Probably your patient has having an anxiety. So you have to treat those, okay? You cannot just give an antiarrhythmic medication and call it a day. No, we have to treat the underlying causes or cause, okay? But of course, you have to maintain airway and breathing. You have to administer oxygen to the patient. You have to make sure your patient's connected to cardiac monitor and monitor the blood pressure of the patient, okay? And as you can see here are the most common causes of tachycardia. So you have to find out, okay? If the patient is hypotensive, you've learned this way back that you have to give IV fluids, right? If IV fluids or the isotonic 0.9% sodium chloride is not working, you can add vasopressor like norepinephrine drip, or also known as levofed. But remember, for NCLEX, they will use norepinephrine. Now, if your patient has acute altered mental status, investigate. Probably your patient's having a stroke, okay? And we will discuss stroke in depth next session. Any signs of shock, you will learn shock in critical care. Any chest pain, investigate that. Do 12-lead EKG, right? Rule out, is this pulmonary related? Is this cardiovascular related? Okay, is this acute heart failure? What type of heart failure are we looking at? Is it right-sided heart failure? Is it left-sided heart failure? Is it systolic heart failure? Is it diastolic heart failure? Okay. Now, if any of this is or are the causes, then remember, this is the algorithm, okay? And we taught you that you always start giving antiarrhythmic medication first, okay? And for this adult tachycardia, okay, whether it's an SVT, and I will discuss SVT in the next discussion, okay, is that you give adenosine 6 milligrams IV push, and the second dose is 12 milligrams if required, and it's an IV push again, okay? And we will discuss this in a separate discussion because this is more for SVT, okay? So what do we do if they have tachycardia? First, we give them, beta blockers or calcium channel blockers. And then if it's not working, then we synchronize cardiovert them. Okay? Now, if not, then we have to further investigate. Okay? Remember, again, I will discuss this separately. This is for SVT. Okay? And the most common that we give for sinus tachycardia is beta blocker or even calcium channel blocker. Okay? And then we consult EPS again. Are we clear on that? Okay. So let's move on to SVT. Okay. So SVT, the heart rate is 150 to 250. And SVT means that the arrhythmia is coming from an electrical loop. Okay. So as you can see here, this is the normal. This is what it's supposed to be. But with SVT, what's happening is that it's above the ventricles. So what happens is instead of the conduction going from AV node down to bundle branches, what happens is from there, it goes around. Okay, and it's called reentrant. So that's what causes SVT. Okay, and with SVT, you have to give them adenosine. First dose 6 milligrams, second dose 12 milligrams if required. If it's still not converted, then we do synchronized cardioversion. And with synchronized cardioversion, let's go up here again, because SVT is a part of adult tachycardia with pulse algorithm. With synchronized cardioversion in here, you can see that we're only giving a small dose of energy. We can start from 50 and then you can go up to 200. Again, it depends on the policy and procedure of the hospital where you work at. Okay, so I hope this is clear. Okay, again, I'm gonna repeat: a sinus tachycardia, first thing you give, beta blocker or calcium channel blocker. Okay, make sure you do vagal maneuver first and then give the medication, and then if you have to synchronize cardiovert, you have to, but again, think again, is this SVT? Okay, then consult EPS. Now, if it's a true SVT and you investigate, I'm gonna repeat, the medication is adenosine 6 milligrams first dose. Second dose would be 12 milligrams if required, and synchronize cardiovert the patient. Okay, giving a small dose of energy from 50 joules to 200 joules. Now let's move on to AFib and A-flutter. Okay, and a lot of students and even nurses interchange these two, but you really have to look at the cardiac monitor or even your 6-second EKG strip or even your 12-lead EKG strip. Okay, so let's differentiate these two. With AFib, okay, it means that the atria is quivering. Okay, and the thing with AFib and A-flutter, it means that the atrial kick of the heart is losing. Okay, and that's not good. Now with AFib, as you can see here, look at your P waves here. Okay, that's fibrillatory waves. When you look at atrial flutter, look at that. It's sawtooth pattern. Okay, so in NCLEX or even with your exams, if you're trying to identify either it's AFib or A-flutter, look at their P wave. Okay, if it's very prominent and it's sawtooth, that's a flutter. If it's very small, it's fibrillatory waves, that's AFib. Okay, so what do we do with AFib and A-flutter? Okay, before we get into that, keep in mind, okay, when you imagine if your patient has AFib and A-flutter, let's draw the right atrium and the left atrium. What's happening in the atria here? They are quivering. So it means if they are quivering, the blood in here that's supposed to go to the ventricles are not going to the ventricles fully. Okay, some of it go, some of it stay because it doesn't, pump properly. So what's gonna happen to the blood? It stay in this area. Okay, it stay in this area. So what happens? There will be blood stasis. There will be clots forming, and those clots can be pumped to the pulmonary circulation causing PE, or it can be pumped to the systemic circulation that can cause stroke. So in short, the most common complications of AFib and A-flutter are stroke and pulmonary embolism. So in short, as a nurse, if your patient has any of these dysrhythmias, you have to check their respiratory status, cardiovascular status, and also their neuro status, and that will tell you if your patient is having any of the complications that I mentioned. Okay, now if your patient has a new onset, it means they never had it and they just had it, what do you do first? Okay, the first thing you have to do is you have to give an antiarrhythmic drug. Okay, what antiarrhythmic drug you have to give? You have to give amiodarone. Okay, you have to give amiodarone. First dose is 300 milligrams IV bolus, and you give that within 10 minutes. And then after that, you give 150 milligrams IV infusion. and this runs 1 milligram per minute. Okay, and this can be given up to 18 hours. And after 18 hours, remember, if your patient's on it, you have to convert the amio IV infusion to PO. Okay, now the amiodarone will be one of the maintenance of your patient. Now that is to fix the arrhythmia. Okay, but remember, with amiodarone, you have to be careful using this because it can drop the blood pressure. So make sure you monitor their blood pressure very closely. Now, as I said earlier, with AFib and A-flutter, it can cause, or it can create clots that can be distributed to the pulmonary circulation and systemic circulation. So what do we do with those clots? Okay, acutely, you can give heparin. Okay, IV infusion, and this is titrated. Okay, in IV infusion, you have to monitor their PTT, and remember the therapeutic level of heparin for you to know that it should work properly. PTT needs to be between 56 to 82 seconds. Okay, now you can also start the warfarin PO daily. You might be asking, why should I just go ahead and start warfarin and not heparin? Because remember, guys, you've learned this in pharm that warfarin works after 3 days that it started. So it means you started this together on day 1, and on day 3 you have to by the end of the day, you have to discontinue heparin and continue warfarin. Okay, in some other hospitals, or even some healthcare providers, they preferred giving factor 10A inhibitors in addition to, or not giving warfarin. So it really depends on where you work and where you're exposed and what's the policy and procedure. But I'm just letting you know that in some evidence-based practice, they prefer giving apixaban, rivaroxaban. How would you know if it's a factor 10A inhibitors? Look at this XA right here. Okay, so I'm just letting you know, the first thing you have to give is heparin. Okay, because you don't want those clots to form and to be redistributed in the body. And start warfarin also on day 1. Day 3, by the end of the day, discontinue heparin, because for sure warfarin starts kicking in and working. Okay, and remember, with warfarin, you've learned this in pharm, you have to monitor PT-INR. Okay, now hopefully this AFib and A-flutter will be under control. Okay, because if not, your patient will need ablation. Okay, so as you can see with ablation here, they will use a catheter right there, and this is the tip of the catheter. Okay, and what they will do is they will ablate. Ablate means burn or cauterize. So they will cauterize the area that causes the arrhythmia. So as you can see in this image right here. Okay, so your patient will have AFib ablation. Now, after AFib ablation or atrial fibrillation ablation or A-flutter ablation or catheter ablation, okay, different books, different evidence-based practice uses different terminologies, and you have to be familiar with that, is that after the procedure, you have to make sure you check level of consciousness. Okay, because there's a possibility that your patient can throw a clot. Not only that, you have to monitor their respiratory status. Okay, because there's a possibility again that your patient will throw a clot during or even after the procedure, and this is very important, and to be honest with you, it's the most common overlooked type of assessment. Okay, now there's another image here that can tell you that in other evidence-based practice, they're saying that some of the arrhythmias that causes AFib and A-flutter are coming from this area. Okay, as you can see, it's around the pulmonary vein that they're saying that there's an aberrancy occurring between pulmonary vein and left atrium. Okay, so I'm just sharing that because that's one of the newest evidence-based practice about AFib and A-flutter. So let's move on now to the VTAC, VFib, asystole, right? So let's start with H and T's. So with pulseless VTAC or VTAC with pulse, VFib, or even asystole, the most common causes that you have to investigate are the H and the T's. And you have to know this by heart, okay? So the H stands for hypoxia, hypovolemia, hydrogen ion or acidosis, hyperkalemia, hypothermia, toxins. Okay, maybe your patient had toxicity, probably acetaminophen toxicity, opioid toxicity, cardiac tamponade, tension pneumothorax, or probably your patient has thrombosis. Okay, either pulmonary or cardiovascular or coronary. Now, if any of these are the cause of the cardiac arrest that I mentioned, all the arrhythmias that I mentioned, then you have to fix that. Okay, treat the underlying cause. How? If your patient has hypoxia, give oxygen. Okay, hypovolemia, give fluids. If your patient has acidotic, give sodium bicarb. If your patient has hypo or hyperkalemia, fix that. Okay, and you've learned fluid electrolyte imbalance about how to fix hypo or hyperkalemia. If your patient is hypothermic, warm them up. If they have toxins, remove that toxins from the body, give the antidote. Okay? Cardiac tamponade, do pericardiocentesis. Tension pneumothorax, we need chest tube. Thrombosis, give anticoagulant like heparin. Okay? Or TPA, depending on the protocol. Okay? Now, let's move on to the first dysrhythmia. And as I said, you have to investigate what's the causes or what's the cause or what are the causes. Okay? Look for the H and the T's. Now with VTAC, okay, we have this strip right here and we have this one. Okay? You might be wondering, how would I know if it's VTAC? Look at the QRS complexes. Okay? So as you can see, this is monomorphic VTAC. Monomorphic means they have the same image when you look at the QRS complexes. As you can see, right? They're monomorphic. When you look at the second image here, this is polymorphic VTAC. Okay? And actually, this polymorphic VTAC is torsades de poids. And how do you fix this torsades de poids? You've learned this in fluid and electrolyte imbalances. You give magnesium because this also represents hypomagnesium. Okay? But let's focus on this monomorphic VTAC. What's going on in the heart? Okay? So what's happening is, again, there is a reentrant arrhythmia in the ventricular wall. That's why your patient is producing this type of arrhythmia. And with VTAC, there are two types, okay? There is VTAC with pulse, and there is pulseless VTAC. Okay? So let's discuss the difference of their management. Okay? So there's no space. So I'm gonna erase this part right here. Okay. Let's start with VTAC with pulse. So VTAC with pulse. So it means your patient is alert and conscious. I remember my patient had this VTAC with pulse that I have to cardiovert the patient. Okay? But of course, ideally, you want to start with giving medication first. Okay? So what medication to give? Again, amiodarone. Okay, same dose. You can give the bolus and then you can give the IV infusion. If it doesn't work, start lidocaine. Okay? Now, if it's still not converting using the drugs, then you'll do synchronized cardio version. And as I said, this is painful. You have to pre-medicate your patient and you're giving 50 to 200 joules. Okay? And of course, you have to find out what are the possible causes. And again, look back again on your H and your T's. Okay? So that's for VTAC with pulse. Now, let's go to pulseless VTAC. Now, the good thing about pulseless VTAC, not a good thing, but the good thing to remember is that with pulseless VTAC, whatever management you do with pulseless VTAC is the same with patient who has BFIV. Okay? So NCLEX tip for pulseless VTAC and BFIV, your priority action is to defibrillate the patient. Okay? Priority. Defib the patient and then do CPR. Now, if you don't know if this patient has pulseless VTAC and BFIV because there's no cardiac monitor connected to your patient and the patient just had cardiac arrest, then do CPR first. Okay, and I hope that's clear. Now, before I discuss the management for pulseless VTAC and BFIV, because they are the same, let's just look at BFIV here. So this is what BFIV looks like. So as you can see here, these are the characteristics of BFIV. Okay, you cannot really discern any of the PQRS. Okay, it can't. And when you look at it, this one is coarse BFIV. Okay. So now let's go here in the algorithm that American Heart Association created for pulseless VTAC and BFIV. Okay. So as I said earlier, NCLEX tip, if the arrhythmia is already identified as pulseless VTAC and BFIV, your priority is to shock the patient. If you don't know what's going on to the patient, the arrhythmia was not identified, patient becomes unresponsive, no carotid pulse, you have to start CPR. And here, this is a review of the quality of CPR. Okay? You need to push hard and fast, at least 2 inches. Fast, how fast? 100 to 120 per minute. And allow complete chest recoil. No interruptions. Okay? Or minimize it. Avoid excessive ventilations. Okay? Remember, change compressor every 2 minutes because we want to avoid fatigue. Okay? Now, so you can see here, if you don't know what's going on with the patient, you don't know if it's pulseless VTAC or BFIV, you start CPR. You give O2, then you attach the monitor. Once you identify that it is a shockable rhythm, then you shock the patient, as you can see here. Shock or defib the patient. Okay? Now, when you defib the patient, continue CPR. Okay? While you're continuing CPR, you monitor the CPR quality. Okay? And then, what drug do you give? You give epi. Okay? Every 3 to 5 minutes. It's 1 milligrams every 3 to 5 minutes. You give amio. This is the dosing in here on your right side. You give 300 milligram bolus, second dose is 150. Okay? If amio is not working, you give lidocaine. Okay? Consider advanced airway, so endotracheal tube, and treat reversible causes, which you have to investigate if the possible causes are in this list. Okay? The H and the T's. Okay? And hopefully, your patient will come back. Your patient will have ROSC, ROSC means return of spontaneous circulation. It means you have a pulse, you check the blood pressure, there is blood pressure, then that means your patient came back. Okay? I hope this is clear. Again, I'm gonna repeat. If the arrhythmia is not identified, and the question in NCLEX is what's your priority? Okay? Remember, not identified. Then you have to do CPR. If it is identified and telling you, hey, this patient is having pulseless V-tach and V-FIV, your priority is to defibrillate the patient. And you might be wondering why, okay? So I'm gonna draw here. Just wanna make sure this is understood. Okay? This is your right atrium, left atrium, right ventricle, left ventricle. Okay. With pulseless V-tach and V-FIV, you have to look at the ventricles. What's going on in the ventricles? What's happening is that the ventricles are quivering. So it's still there. However, it doesn't create enough circulation and enough perfusion. That's why when you assess the pulse of the patient using their carotid, there is no pulse because the quivering of the ventricles, it's not enough to deliver enough perfusion and circulation in the body. That's why you cannot find the pulse. But your goal is to restart the heart because they are quivering. Okay? That's why you have to defibrillate first. If pulseless V-tach or V-FIV are identified in the NCLEX question. Now, if it's not identified, you do CPR. Okay? And what does CPR do? Let's go there. Okay, so it's clear. What does CPR do? Okay, cardiopulmonary resuscitation, right? CPR stands for cardiopulmonary resuscitation. It means that you have to compress the heart, do compressions. And when you do compressions, it's like you're pushing or trying to create circulation and perfusion in the body. And you do CPR to a patient that has a systole, right? A systole means the heart stops completely. Atria and the ventricles are not working anymore. So you're pushing them to work. That's why you push them. While with pulses V-tach and V-FIV, the ventricles are still there, but they're quivering. But you want to restart the heart by defibrillating it to create perfusion and circulation. But remember, defib is not the only answer here. You have to do CPR also after that. Okay? That's why it's very important to understand this concept so that you'll be able to answer any NCLEX question regarding any of these arrhythmias. Okay? I hope this is clear. So let's move on to... Okay, this is just me showing the pads, and I know we showed this already, and you know this already from clinical. Okay, this is the LifePak Medtronic, and again, some hospitals use Zoll. Okay, it's the same. And with defibrillating the patient, how to defib, make sure everyone is clear, no one's touching the patient because you don't want to shock anyone, okay? Just want to shock the patient. So to defib, you want to press energy select, okay? How much? You can start from 200 to 360 joules, okay? Then you charge, make sure no one is touching the patient, check everyone around you, and then shock the patient, okay? And then proceed doing CPR. So as you can see in shocking the patient, this is monophasic. It encapsulates the heart to shock it and restart it. Now, once your patient is stabilized, you have to consult EPS. electrophysiology studies to place AICD. And AICD stands for Automated Implantable Cardioverter Defibrillator. Okay, so your patient will have that once they are stabilized. Now the next one is ventricular asystole versus PEA. So let's differentiate first the ventricular asystole versus asystole. When you look here, okay, your patient has ventricular asystole. It means that the ventricles are not working anymore. But as you can see, it's not a straight line. It means that you can see very small, very minimum, okay, in here, the P waves. It means the atria is still there, but again, it's the pumping action of the atria are not enough to deliver or make sure that the circulation and perfusion are enough for the body. Okay, well, this one is asystole, so completely the atria and the ventricles stop working. Okay, while PEA stands for pulseless electrical activity. So it means that your patient doesn't have a pulse, but in the monitor you can see that they have a rhythm. Okay, that they have a rhythm, and that is pulseless electrical activity. Okay, and you will also see that. And remember that the treatment for ventricular asystole versus asystole or even PEA are the same. Okay, so let's look at again any of the arrhythmias I mentioned. Find out what's the cause. Look for H and the T's. Now, what's the algorithm for asystole and PEA? This is what you have to do. Start CPR, attach the patient in O2 and the monitor or defibrillator. Okay, rhythm is not shockable. Okay, considered asystole or PEA. You do CPR for 2 minutes. That's the first thing you have to do. And you put an IV and you give epi. And consider putting endotracheal tube to the patient. Okay? So as you can see here, every 2 minutes, you have to reevaluate and analyze what's the rhythm of the patient. So it means every 2 minutes, everyone should stop whatever you're doing and look at the cardiac monitor. And if you see that it's still a systole or PEA, you have to continue doing CPR. You have to continue giving epi, okay, 1 milligrams every 3 to 5 minutes. And you still need or keep finding out what's the possible causes. Okay? So that's what you're supposed to do for PEA or a systole. Now, of course, some patients, they survive after any of the arrhythmias that I mentioned, but some, unfortunately, they don't survive. Okay, now if they survive from this arrhythmias that I mentioned, then you have to do post-cardiac arrest care. So with post-cardiac arrest care, what do? We do induced hypothermia. And remember, the criteria for this induced hypothermia is that the cardiac arrest needs to be witnessed. Okay? Witness, it means you saw it, you started CPR, you tried to save the patient. So with induced hypothermia, the goal is 32 to 34 degrees Celsius target temperature. So in layman's term, induced hypothermia means you will make the patient very, very cold. Okay? And you want to make sure you connect the patient in an ice machine. And I'm gonna show you what the ice machine looks like. As you can see here, it's saying here also that you can apply ice packs. The problem with ice packs, and I did this already once, okay, for 10 years in my CVICU experience, is that the problem with ice packs is that it's hard to control the target temperature. So I would highly recommend for you to use an ice machine, and I'm gonna show it to you. Okay, and of course, in icing the patient or making the patient cold, we use normal saline. Okay, you maintain the induced hypothermia for 12 to 24 hours. You need to monitor your patient, but remember, since you want the patient to be cold, you need to sedate and paralyze the patient. Yes, you have to paralyze them, okay, using neuromuscular blocking agent. So like for example, the most commonly used is the vecuronium. Okay, and for sure you heard about this already in pharm. Now the problem with induced hypothermia, there are some complications you have to watch for. You will see some electrolyte imbalances, hypotension, even pneumonia. Why pneumonia? Because if the patient is on induced hypothermia, you don't want to suction them. You want to suction them as needed, but as much as possible, you don't want to create any stimulation. So if your patient is on induced hypothermia, you don't want any of the visitors to stimulate them nor talk to them, okay, for 12 to 24 hours. Because the goal of induced hypothermia is to decrease the oxygen demand in the brain and also in the body. That's why we're making them cold, okay? Another problem with induced hypothermia is sepsis, okay? Because we're using an IC catheter, and I'm gonna show you what the IC catheter looks like. It can also cause hyperglycemia because again, when the patient is cold, the glucose tends to climb up as a response to the cold temperature, and the body is under stress. And you've learned that way back in anatomy and physiology. Dysrhythmias can also happen, okay? The colder the patient gets, the lower the heart rate will be, okay? So you will see that. But some patients, the warmer you put them on, the dysrhythmias will occur, and it's worse than when they are cold. So you really have to watch them very closely. Coagulopathy, okay, since they are cold, of course there's a possibility their blood will be in stasis, okay? So again, in some protocols, we want to give them also heparin IV infusion, okay? So I'm gonna show you the ice machine that we use. Okay, this is the ice machine. So as nurses, we're the one who will set it up, okay? As you can see in this monitor here, this is where you will put your target temperature, the 32 to 34 degrees, depending on where you work. And as a nurse, we will set it up, okay, in there. Okay, it's easy to set up. You also have to prime the tubing using the normal saline. And we usually use normal saline 500 ml. And remember, those normal saline is not given to the patient. It recirculates in the tubing, and that is used to make them cold. Okay? And I'm gonna show you the IC catheter here. So this is the catheter that we use for induced hypothermia. And remember that there are no holes, or there is no hole in this catheter, okay? So in short, when you prime it with normal saline and the normal saline goes to this catheter, the normal saline should just recirculate, okay? And the bag that I mentioned earlier should not be emptied. If it's emptied, it means that there's a hole or there's a leak going on in any of this part of the catheter. So you have to investigate, okay? So in summary, for this dysrhythmias management, and I know it's very long discussion, is that you really have to, the first thing you have to do for any dysrhythmias is you have to identify and treat the underlying cause. And your priority action is depending on the case scenario given to you in NCLEX. But ideally, you need to maintain their airway and breathing, and you need to make sure they are connected in a cardiac monitor. Okay? And again, you have to know also the medications and even the doses. Okay? Because again, this is very important, especially when you become a nurse, and when you're already a nurse, you have to know all of the antiarrhythmic drugs. Okay? Another thing, you really have to know H and T's by heart. Okay? And the sixth key point is that you really have to know the management, and why are we defibrillating a patient versus synchronized cardioverting versus doing CPR. The last thing to do is that you have to know the post-cardiac arrest care. So, because what do you do after the patient return of spontaneous circulation? And I just discussed it. We have to do induced hypothermia to the patient for 12 to 24 hours to save the brain, and hopefully we can stabilize the patient. And I hope this discussion will help you to further understand the dysrhythmias management. And all of the information I mentioned to you, again, I'm going to repeat, is from American Heart Association 2015 and also 2018 updates. In addition, it's also based on the Lewis MedSurg book. Thank you.